Good morning. Thank you, Dr. Greenblatt, for the introduction. And yes, as he was saying, my name is Michelle Metzler. I'm a recent graduate of the Duke Physician Assistant Program, and it is an honor to be amongst my incredible leadership colleagues and to be able to speak with you today. I would like to share what I learned this past year about mental health advocacy and transportation of patients during a mental health crisis. I chose this topic because during my behavioral medicine rotation with psychiatry consult in the North Carolina Emergency Department, I was surprised and shocked to learn that law enforcement, often with the use of handcuffs, is used as a main form of transportation for patients in need of mental health care. During my time in the Psychiatry Evaluation Unit, also known as the PEU, patients repeatedly expressed confusion, angst, and anger at the use of law enforcement during their evaluations, but also for their transportation to the ED and from the PEU to the additional care they needed. The use of law enforcement seemed to only further traumatize these patients in much need of care. If we could all just please take a moment right now to think about what it might feel like to be handcuffed when you're most vulnerable and in need of care during an emotional, physical, or mental health crisis. On the next slide, there's a little background. In any given year, 1 in 5 adults in the United States has a diagnosable mental disorder, and 1 in 25 adults has a serious mental illness. According to the American Psychiatry Association, people with mental illnesses are no more likely to be violent than those without a mental health disorder. In fact, those with mental illnesses are 10 times more likely to be victims of violent crime. Furthermore, people with untreated serious mental illnesses are 16 times more likely to be killed during a law enforcement encounter than other civilians. And 1 in 4 fatal law enforcement encounters involves an individual's serious mental illness. The National Substance Abuse and Mental Health Service Administration, also known as SAMHSA, acknowledges that in too many communities, the crisis system has been unofficially handed over to law enforcement, and that the current approach to mental health crisis care, which I will refer to as crisis care moving forward, is patchwork, delivers minimal treatment for some people, and leaves many to fall through the cracks. This results in 56% of North Carolina adults with mental illness not receiving treatment, multiple hospital readmissions, life in the criminal justice system, homelessness, early death, and suicide. As previously stated, the current approach to crisis care is patchwork, and this includes transportation. There is no set federal standard of transportation during a crisis, which leads to differences from state to state and within states. In North Carolina, there are 7 different local management entities, and even within these LMEs, the source of transportation varies. North Carolina does encourage alternatives to law enforcement for transportation use, but there's no law or policy stating that alternative solutions be used. The current policy affecting crisis care transportation is North Carolina Session Law 2018-33. It was an attempt to improve the delivery of behavioral health services in North Carolina. However, when this act became law in 2018, it did nothing to improve the transportation of mental health patients to the care they need. This is because the current statute only suggests transportation should be provided by non-law enforcement, but did not make it mandatory. It also did not approve any funds or any other forms of transportation and did not require tracking use of handcuffs by law enforcement. In the setting of our current haphazard approach to mental health care, SAMHSA recognizes the country's approach to crisis care must be transformed and has created Best Practice Toolkit. The Toolkit recommends the use of mobile crisis team services in lieu of transportation by law enforcement. The National Association of State Mental Health Program Directors are also dedicated to transforming mental health systems and support the movement to increase mobile crisis support teams. So all this research suggests community members and patients with mental health diagnoses are not more violent. Law enforcement involvement is inversely associated with safety. There's no standard of transportation, and the use of law enforcement is not best practice. So given this research, why are we using law enforcement to transport community members, patients, and loved ones experiencing a mental health crisis to the care they need? To help answer this question, I used key informative interviews. My goal was to connect with a minimum of 15 differing informants. A diversity of informants were chosen, including mental health agency representatives, community leaders, healthcare providers, professors, and law enforcement officials. Additional questions were also formulated and asked, as you can see, and you can see those questions here on this slide. Time during the interviews was also reserved for the key informant to provide any additional information and comments, and there were a lot of candid conversations that happened during that time, which I was grateful for. The next two tables will help distill the responses received from the key informant interviews. The overwhelming response by all informants to the main question, that main question of why are we using law enforcement for mental health crisis care, was the need for new legislative policies or policy changes. Limited alternative to the use of law enforcement for transportation, underfunding of mental health care, and the imbalance of community-based services were also consistent responses as to why. Additionally, the use of law enforcement was not thought by informants to be for safety reasons, and only in rare situations was the use of law enforcement thought to be safer. On the next slide, you can see a few more of the questions, and there was a resounding no to the use of law enforcement as being best practice for crisis care. There was also clear solidarity in responses on the effects of using law enforcement as being criminalizing, stigmatizing, detrimental to care, and discriminatory towards Black and Indigenous people of color and community members of lower socioeconomic status. The need for alternative transportation solutions and funding through legislative policy changes was made clear. So what can we do? What can we do as healthcare providers? We need to have a better understanding of existing policies, especially the involuntary commitment process, which unfortunately due to time, I'm unable to share more info about this in this presentation about that, but it's discussed at length in my paper, and as is like upcoming federal policies that are promising. Key informants did recommend, though, at the very least, we need to be having conversations with family, friends, and colleagues as part of an effort to destigmatize mental health diagnoses. All informants also encouraged me to urge you, healthcare providers, to get involved in making policy changes at a local and state level. In regards to the informant responses I've been sharing in my project in general, there were some limitations, namely the number and diversity of informants interviewed. My goal was to connect with a minimum of 15 diverse informants. However, making it into someone's busy schedule to complete interviews was one of my most challenging hurdles, even in the advent of Zoom meetings. But despite repeatedly reaching out and petitioning informants, I was only able to interview 7 of the 15 informants chosen. Furthermore, all the law enforcement officials I contacted declined to be interviewed or did not respond to my persistent emails or voice messages. The inability to complete a larger number of interviews with a wide range of informants reduces the power of the results and does increase bias. Despite these limitations, I embraced the leadership skills provided and promoted by the North Carolina Leadership College, and I made connections. I gained a better understanding of governmental affairs, policy development, and current legislative policies. And I took action to advocate for patients. Early on in my project, I connected with members of the North Carolina Commission on Children with Special Healthcare Needs. I learned that they expressed a similar concern with the use of law enforcement for transportation of patients in need of mental health care. The commission had requested language changes to the bill that became current session law that I discussed earlier. The commission recommended more humane and less traumatizing forms of alternative transportation and requested tracking use of restraints. Unfortunately, the frequency of restraint use by law enforcement was referred to as shackling by many of the informants and is also a term used by many in the mental health industry. Unfortunately, legislators did not heed the commission's advice, and as you learned earlier, the resulting session law affecting transportation did nothing to elicit any meaningful change. I also made connections with student and state organizations, particularly a student chapter of White Coats for Black Lives, in which I was a founding member, and Peer Voices North Carolina. We worked together to advocate for policies affecting mental health care. In advocating for current bills this legislative session, I also formed a healthy line of communication with many state representatives. I even have many of their numbers on speed dial. I'm not sure what that says about me. Anyway, in order to have policy conversations with legislators and to advocate for better mental health care, I researched the bills being sponsored this legislative session and learned of several bills, but 2 in particular, HB 788 and 786. These bills attempt to address more humane mental health care transportation with a primary focus on improving mental health care access. It is much needed legislation impacting mental health public safety policies, and these bills take steps towards decriminalizing the transportation of care provided during a mental health crisis. Understanding the broader concept of the leadership project being not only to gather data, but also influence change, I committed to advocating for these bills, and I emailed North Carolina Healthcare Committee members to share my project information and requested time to speak with them. Also tried to do so during a White Coat Wednesday, which I encourage you all to join next year, I guess, when that's happening. Not only did I decide to take personal responsibility in promoting positive changes, but I also felt equipped with the leadership skills to drive transformation by motivating and inspiring other healthcare providers and students to take action. So during this past year in Leadership College, I learned entering the public policy arena is intimidating, but it's possible. And the North Carolina Medical Society will support you through this process. I encourage you to lean on them and look at their websites and follow the political, I can't think of what they're called right now, videos that are offered every Friday. It's a great source of information. This project also reassured me of the importance of advocating for patients and policy changes, and helped to highlight the necessity for healthcare providers to take a role in advocating for the delivery of quality care at a systems level. I may be speaking to the choir, but I feel like I need to repeat that again. It helped to highlight the necessity for healthcare providers to take a role in advocating for the delivery of quality care at a systems level. I also was reminded of the importance of hope. The need for hope was a resounding message by all informants. Further research is definitely warranted. Conversations need to continue, but also more disaggregated data is needed on race and PEUs, the amount of time under IBC, and the frequency of restraint use. The effectiveness and impact of emergency commitment is increasing treatment for people with mental illnesses, and those unable to meet basic needs must also be evaluated. And as stated earlier, there's a call for healthcare providers to engage in legislative advocacy and voting. I plan to continue being an advocate, and I hope this talk inspires you to become an advocate too. Earlier, I forgot to mention that I also learned that being an advocate takes so much time and effort. I'm hoping that info on this slide will eliminate some of the basic barriers to being an advocate. And advocacy starts by voting. So first and foremost, vote. Did you know that physicians are 9% less likely than the general public to vote and 22% less likely than attorneys to vote? Thanks to listening to our prior MEDTalks, this is yet another thing I learned during my Leadership College year. And let's be better than attorneys and change these statistics. There's an opportunity to do so in the upcoming municipal elections that are on November 2nd. So if y'all would please take a moment now to either bring up vote.gov website or text Vote Health to 3444. I'm going to give you all a moment to do that. So then now you'll have that on our next break. You'll be ready to confirm that you're registered to vote. And if you're not registered yet, you can register to vote. Also, please join me in having your representatives on speed dial. I don't want to be the only one calling them. You can find your representative's contact info at commoncause.org. And then I encourage you to just put it in your contacts list. Better yet, you can also keep the U.S. Capitol switchboard number handy for any time you want to contact your U.S. senators or House representatives. You can see that number also on this slide. Finally, I would like to thank the North Carolina Medical College and Medical Society for being inspirational and enlightening. And I give special thanks to my passionate and brilliant Leadership College colleagues. I look forward to hearing all your talks to come. Also to Dr. Greenblatt and Dr. Matson for their guidance, and Aubrey for her sunshine yellow encouragement and support. This next slide is more resources, and then my reference pages. And lastly, I appreciate you all being here today and listening. I'm happy to take any questions now if there's time, which I believe there will be.